we have Dr. Rajan Gadhia, who specializes in vascular neurology. He is an assistant professor of clinical neurology at the Houston Methodist Academic Institute, assistant clinical member at the Houston Methodist Research Institute, and program director of the Vascular Neurology Fellowship at the Stanley H. Appel Department of Neurology. His clinical interests include hyperacute ischemic and hemorrhagic stroke management, neurocritical care, telestroke evaluations, novel neuroimaging, and outpatient primary and secondary stroke prevention. He also has a keen interest in TBI and sports-related concussion.
Thank you, Amber, and thank you, Dr. Garg and Dr. Volpe, for this wonderful 360th conference looking at stroke. I've been tasked in the next 15 minutes to make everyone an expert in telestroke, telemedicine, and how to run a system cohesively. And so I'm going to try to do that, and you can boot me off the stage if I take too long. I have no relevant financial disclosures. And so just to start off with a quick outline of what we're going to talk about, and I think Dr. Kalafala has set up the stage very nicely of the importance of having system cohesion when you're making transitions, such as what we will be doing within our own system, going from alta-place to tenecta-place. And Telestroke certainly was a setting stage for that system cohesion about 7 years ago when we started the program. We'll talk about definitions and terminology. We'll look at some of the models of telestroke care and sort of our multi-point or distributed model that we have here at Methodist. We'll look at some clinical timelines. Those of you that have been to any of my talks know that I love timelines. We'll talk about some of the benefits and how to build a program. We'll run through a case, and then we'll look at future directions. So some basic definitions. Telemedicine is the use of medical information exchanged from one site, the distant site, to the originating site using electronic communications in an effort to improve consumer health status. You use video conferencing, still images, video clips, and certainly telemedicine encompasses a broad range in many different acute and non-acute environments. So teleneurology is essentially using telemedicine in the field of neurology, both acute and ambulatory care, and telestroke is an extension of that into stroke care. So the term was first published by Levine and Gorman in 1999. The initial impetus was because we wanted to ensure that you had a vascular neurologist or a neurologist at the very least making an appropriate decision on use of TPA. And we've all probably in the last 3.5 years experienced some form of virtual avenues for meetings, for clinical care, for research, whatever it may be. So we've all become recent experts, but I'll highlight that stroke has been utilizing telemedicine for the last 25 years. And so this is kind of what telestroke looks like. We don't have those old video cameras anymore. We've grown a little bit to more modern carts and iPads, but essentially the impetus is EMS will see a patient out in the field, we'll get a pre-alert. Typically that pre-alert will go to the teleneurologist that's on call or the on-site neurologist. We'll get everything ready, we'll get the scanners cleared. The teleneurologist will typically start digging into the chart. Luckily, we've got electronic healthcare records. If we have names or any patient identifying information, we'll start very early on. We'll oftentimes even call families to confirm last known well, start consenting for TPA. And as the patients are in the scan, we're doing all of this kind of at the bedside with the family members or any of the bystanders, sometimes even with EMS. And the whole point is to shave off as much time as possible. Every minute, one thing I want you to take away from today is every minute that we wait, we're losing nearly 2 million brain cells, neurons that are not coming back. And so when you start thinking of that, when you talk about scene time of 10 minutes, to me that's almost 20 million neurons. You talk about an extra 10 minutes, that's another 20 million neurons. So every minute we can shave off is going to improve the outcome of our patients. So Telestroke is really involved into essentially any element of stroke care, and I'm going to show you some models. The traditional model many people think of as a hub and spoke. We, to some extent, are a hub and spoke model, but we really are more of a distributed model because we have some providers that are practicing as medical directors from many of our primary stroke centers and our thrombectomy centers, and we actually even have a comprehensive stroke center within our system of care. And here it is kind of showing you on the top left, you can see that hub and spoke model. We've grown away from that to a more multi-point at the bottom left telestroke model where we have neurologists not only in the Texas Medical Center, but we've got our medical directors across the Woodlands, Willowbrook, many of our other hospitals, and many systems of stroke care are going to a multi-point model. Of course, there are for-profit companies that provide specialized telemedicine care as well. And so how does this bring us to system cohesion? Are we like the left picture or the right picture, where if one of those sort of breaks, maybe in the left picture, you'd probably still survive with the rest of the folks there? Are we on the right, where you can just break the chain? Or is someone very smart who's sitting here in this audience kind of gave me an example, which is we really function as gears, right? All of us kind of work together as a system. And I think telemedicine has changed the landscape of not only of care, but really of our own existence since the pandemic, certainly. And how are we going to define a system? Does it really stop at the bounds of what we define within our own Houston Methodist system, for example, or Memorial Hermann, or whatever the case may be? Or can that system really go outside the bounds of what we traditionally define as system? Certainly, we can provide this care in a variety of settings. We can obviously do it in emergency rooms. We can even do it in the back of an ambulance with our mobile stroke units. We can do it in PACU settings, rehab settings, so on and so forth. Anywhere where you can essentially get a camera set up and have some component of imaging, we can probably make treatment decisions. Other uses of telemedicine, and we do go beyond clinical care here. I think recruitment in acute stroke trials is very important. Most of the recruitees in trials or patients that are included in trials are coming through academic medical centers. But we know if you want to have a generalizable trial, you need to include patients who are really out in the community, which is really a true representation of the patient populations that we're going to be treating. Certainly use for family meetings and other academic teaching opportunities, which we've all become experts in. And so here's a picture of our beautiful research institute. We are working on this with our research institute, Dr. Britz, and our neurosurgery departments to start to improve the enrollment techniques and broaden our horizon on enrolling patients into our clinical trials. So I'm going to walk you through a quick case, and I want you to keep this in mind. As far as disparities of care, which is a big impetus for why we started Telestroke and why my passion exists, is that we've got geographical disparities, we've got racial disparities, we've got economic disparities, and we've got temporal time-based disparities in care. So think of a 58-year-old woman, which, as our EMS colleague presented to us, in Texas, we're a little bit unique in that 80 to 90% of the people that we see in the emergency rooms are true Jane Does, John Does. Our jobs are really, as detectives, to try to figure out whatever we can about that patient, what medications they may be on, what when their last known well was, what history they have. And so this is a 58-year-old who was found altered and unsteady in a parking lot. And so think of what kind of care this patient is going to get when you come to the Texas Medical Center. If you're presenting to the doors here at the Texas Medical Center at Houston Methodist Hospital versus maybe 100 miles south of Midland in a small rural hospital that may not even be an acute stroke-ready hospital. But what's the same about both of these patients presenting is that the doors look the same, right? And I think we can all probably agree that with this day and age, with the technology that we have available to us, with the providers that we can bring to the bedside, that the care that they receive, at least on the initial onset, you may think of 10 minutes on the scene. I think of the first 10 minutes of when the patient's in the emergency room, where we can make the biggest impact and make triage decisions and transfer decisions appropriately, are no different. And so, as I alluded to, a timeline of what the stroke field has done in the last 20, 25 years, starting from initially, TPA becoming the standard of care. And when I say TPA, I mean alteplase initially. And then almost 13 years later, before we pushed the boundaries with our European and Australian colleagues to the window going from 3 to 4.5 hours, before we started looking at our endovascular benefit for stroke care. And then we've come full circle to now expanding the window for thrombolytic care with our Extend and our Wake Up studies. And you can see there that on the left, it was very simple triage, similar to our EMS folks. You're either yes TPA, no TPA, or you're hemorrhage, to now everything is a draft because every patient is going to have a very personalized care plan. The modified Rankin Scale score, which you all know about, which defines disability, and this is sort of a pictorial representation of what that graph looks like, and you can see a leftward shift to improve benefit with every one of those studies that we talked about. And if you want to talk about system cohesion and growth, I told you to think of things within a system outside of just the bounds of what we collectively call a system. And you can see we started there on the left there with only one comprehensive stroke center. We've now got 2 thrombectomy capable centers within our own subsystem and a comprehensive stroke center. We're growing that, and I think the geographical sort of barriers will be knocked down with the availability of growing Telestroke. And so why Telestroke and why now? Because I think the triage of patient care has changed. The landscape of TPA yes or no, or tenecteplase potentially, rather than alteplase yes or no, and which patients need thrombectomy yes or no has changed. And simply there's not enough vascular neurologists out there to be able to be 3 full-time vascular neurologists at every stroke center. So we can bring the technology and the expertise to the bedside and split the responsibilities. And there's a level 1A recommendation for at least using the imaging component within triage of Telestroke, but certainly a 2A recommendation with the American Heart Association, American Stroke Association guidelines. And I'll skip through some of these slides for the sake of staying on time, but I want to touch on building a stroke program, and this is an important part of system cohesion, is that you really need system support, right? Because when you're building a program that's going to affect the entire system, you need to make sure that everyone, including your executives, your key stakeholders, your medical directors, your ED and inpatient colleagues are all on board for order sets, for a comprehensive approach to making a system switch, for example, from going from alteplase to tenecteplase to avoid confusion. And then building the infrastructure and the team. It includes IT, includes your trainees if you have them, and it includes streamlining documentation as well as imaging tools. I think it's important from a quality standpoint to have a way to monitor the quality of your programs as a system, not just at individual sites, but many of times it's the individual sites that are going to contribute to the system dashboard and ensuring that what you're doing for the care of the patient, whether it's door in, door out times or transfer times or actual thrombectomy times, are all at the level that you want them to be at. And here's an implementation. This is a good example of what Methodist has done with coming up with an agreed upon triage of stroke patients, at least certainly in the after hours here at Methodist. So it's not just technology. There's a number of our folks here who are helping to support the conference today, but it's all the people that are involved. It's everyone who touches that patient, from our EMS folks out in the field. It's our nurses in the ER, in the ICUs, on the stroke floors. It's all the physicians that are involved in the care, and everyone in between. And so here's a little snapshot of our program as it is today, over 7,200 patients that we've been consulted on in a short 6-year period. So let's go back to that case and see what it looks like with a quick telestroke encounter. I alluded to us being detectives, which we truly are. Patient will come in and time is of the essence. So initially we'll use some sort of communication tool. You'll activate the team. In that group alert, you'll have typically a neuro-IR folks, you'll have an OA, you'll have the entire vascular neurology team. Sometimes trainees or nurse practitioners are involved in the triage. And during the detective work, you're doing many things simultaneously. You're making multiple phone calls. You're trying to figure out who that John Doe, Jane Doe is, what medications they're on. At the same time, the patient's in the scanner. You're looking at those scans, and you're getting ready for an acute telestroke evaluation. So you may start that prior to the patient even being there, but you're going to do a quick and dirty NIH stroke scale. You're going to have a baseline idea of whether they're disabling deficits or not, and you're going to make your treatment decision, and you're going to make do the documentation. If the patient's not in a thrombectomy-capable center, you're going to fly that patient or get him on an ambulance and put him on ground to the angio suite. And that's essentially the crux of what we do in a quick telestroke encounter. So what does the future state of telemedicine really look like? And I think we can all probably agree that even more so than what it is now, we're going to see this more included in the AHA and ASA guidelines. I think Telestroke is going to become a more formal component of the stroke system of care. We're going to have not only pre-hospital, post-hospital care, but I think a lot of our accreditation agencies are going to ask the question, okay, I'm glad that a single hospital can provide that level of stroke care, but what do we do as a system? Can your system take care of the patient that's in your region? And I think that that's what's coming in the future. Certainly, AI has been a topic of significant interest, and I think that there's going to be some component of AI algorithms for triaging those patients with the number of patients. It's very different to say, a patient who needs a video evaluation was within 4.5 hours, but when you say that there are really no time windows now, everything is imaging based, that's a lot more patients that you have to be able to triage, and we're going to have to leverage our technology to be able to do that. And I think one thing we can also agree on is that comprehensive systems require comprehensive approaches to patient care, research, education, and so on and so forth, and virtual care is going to be a crucial component of that. And so here are my references, and with that, thank you so much.